Hi, everyone, and welcome to our Cancer Education Series. This series is brought to you by Mercy Cancer Center and also Above and Beyond Cancer. And it is brought to us with a grant from the Rosalie and Sherry Exline Ziegler Fund. Tonight, we're going to talk about cancer incidence and surveillance. And my guest tonight, my friend, is Dr. Mary Charlton. Hi, Mary.
Hi, how are you?
Good. Welcome. So Mary is a Ph.D. She is Associate Professor at the University of Iowa, Department of Public Health, and she is the Director of the Iowa Cancer Registry. So welcome. So Mary, what is the Iowa Cancer Registry?
Well, the Iowa Cancer Registry has been around since 1973. We're about to celebrate our 50th anniversary next year, so we're excited about that. We are funded through the National Cancer Institute and also partially through the University of Iowa and Iowa Health and Human Services. And we track, in theory, 100% of all cancer cases diagnosed among Iowans, with the exception of basal and squamous cell skin cancer, which are very rarely deadly and are very high in volume. So those are the only ones we do not collect. But beyond that, we try to collect information about everybody who has cancer. And that information, the types of cancer, the treatments they received, how long they survived, and that's used by thousands of cancer researchers across the world to help reduce the burden of cancer.
Yeah, most people I don't think realize that cancer is a reportable disease. Not every disease is reportable, but cancer is one. And you mentioned 50 years. Did the creation of the Iowa Cancer Registry come out of the war on cancer that was initiated during the Nixon administration?
Yep, exactly. And that's when they started to fund the National Cancer Institute Surveillance, Epidemiology, and End Results Program, known as SEER. And they originally picked 9 registries to kind of represent the country and start tracking cancer. And Iowa was one of those original 9. We had already a pretty good tracking system in place at the university and in the state. And so they kind of joined forces, and we became one of those very first and earliest SEER registries that represented the Midwest.
And tracking cancer, what are the benefits in terms of cancer control of having mandatory reporting and having, accurate figures around the United States on both incidence and mortality?
Yeah, there's so many benefits, and we're really lucky because, like you said, cancer is one of the few reportable illnesses that's a chronic disease. There's lots of reportable illnesses that are infectious, but having really good cancer surveillance systems allows us to really understand, what is the course of cancer, what types of treatments can impact that and improve prognosis, what types of programs that are run by the state or other organizations, what impact do those have on things like stage of diagnosis for those screen detectable cancers like colorectal or lung or cervical or breast cancer, so we can track that. Understanding the differences in different populations by rurality or by race, ethnicity, understanding where the burden of cancer is high, where we should aim resources and programs, how well those programs are working, and how well we're doing over time in general with both prevention and screening and treatment.
And we're going to take kind of a deep dive into the state of cancer in Iowa. Maybe a little definition of terms. I already mentioned 2 terms, incidence and mortality. Maybe you could define those for the audience. And are there other key terms you'd want to define before we get into looking at the data?
Yeah, that's a great idea. So incidence is calculated as the rate of the numerator is the number of new cases, so newly diagnosed cancer cases, over the denominator, which is the population that could get that cancer. So when we look at rates of prostate cancer, we're looking at the number of new cases of prostate cancer over the number of people with prostates who could get prostate cancer. So that's incidence. Mortality is the number of deaths of a certain cancer type over a denominator of the population who's potentially at risk. So those are kind of the 2 main statistics I'll be talking about.
Right. So those are the numbers we talk about a lot, incidence and death. And so, for example, in the United States, it's about 1.8 million new cancer cases a year and about 700,000 deaths in the United States.
Mhm.
So let's jump in to the data. And so
Okay.
we're going to bring up Mary's slides, and we're going to be seeing some pretty exciting data, and then we're going to talk about what that means. So I'll turn it back over to you, Mary.
Great, thank you so much. So usually, when I kind of give the whole cancer epi talk, I start off with, we in last year, we had an estimated 20,000 new invasive or new cancers diagnosed in Iowa. And I kind of go through, the top cancers: breast, prostate, lung, colorectal, melanoma. Those are always kind of the top 5 in most states. But what I really wanted to focus on is some data. It's a few years old, as you can see from the title, 2015 to 2019. But it's the most recent data that's in the CDC and NCI tool that has all 50 states. It has cancer data from all 50 states, since cancer is a reportable disease in all 50 states. Eventually, each state kind of cleans their data, prepares it, and then it takes a couple of years by the time they put it all into one data set where we can compare and rank the different states. And so this was just all compiled recently. And that's when we learned that Iowa is actually number 2 in the United States for age-adjusted cancer incidence rates during this time period. And that's one other thing I'll mention, that with that age-adjusted term means, in a state like Iowa, we have a larger proportion of older people, and cancer is often, thought of as a disease of the aging. So the older the population you have, the more cancer you would expect to see. So what age adjustment does is it takes kind of a standard population distribution for the United States, and it forces all the states to conform to that same population. So it's sort of standardized. So it takes age out of it. So all these numbers that I'm going to talk about are not due to the fact that Iowa is an older state than some of these other states. It's saying if every state had the same age distribution, which states have the highest types of cancer rates given that age distribution. So that's another thing I wanted to point out.
So Iowa is number 2, that only Kentucky has more cancer cases diagnosed during this time period than Iowa did.
Yes, more cases per capita there.
Per capita, right.
Yeah. Yep,
yes.
Than Iowa. And they have been number 1 for quite some time. Iowa has not been number 2 for quite some time. We've sort of been slowly working our way up the ranks. And in the past, those really highly ranked states often tend to be in that tobacco belt kind of area with a lot of smoking and things like that. That's why I was surprised. Another big risk factor for cancer, besides age, smoking, things like that, is poverty. And we don't, while I certainly don't want to minimize the poverty that we do have here in Iowa, relative to other states, we do not have high poverty rates here across the board in the state. And we don't have any counties that qualify as these persistent poverty counties as they do in lots of other states in the country. So that's another thing that makes this sort of surprising that we have worked our way up so high.
Mary,
go ahead.
No, you mentioned two factors that they sometimes come into play: the smoking rate in the state, and also the poverty rate. What about the obesity rate? We're seeing more and more cancers caused by obesity. One might expect that states that have a higher obesity rate might move them up. And the other factor that I thought of would be, what if a state is really good at early detection? So they've got a good system where they do screening. You might imagine that a state that does really good screening might find more cases, and that would move the incidence up.
Yeah, definitely. And I'm going to talk about both of those things. I think I have a slide solely on risk factors too, but we are not at the top for obesity either. We're not something like number 2. Now, we're not at the bottom. I think we're unfortunately above average there, but we're not at the very top. Now, the screening, your point about screening is very valid and something that we've thought about. So through these slides, I'm going to kind of talk about what's been happening with the screening rates and where we rank in those two. I do think that certainly contributes to it. I also think that we're a really well-funded and aggressive cancer registry about finding cases. Because we are one of those original 9 registries funded through the National Cancer Institute, we've enjoyed a very high level of funding. were run out of the University of Iowa as opposed to a health department. So we have a little bit more flexibility in terms of resources, and analytics, IT, those types of things, where we can really be pretty aggressive in working with our hospitals around the state to make sure that we're catching all of the cases of cancer where they may not have as many, and certainly have more limitations on resources for cancer registries run out of state health departments. So I think that's kind of another thing, but I think throughout the slides, I'll kind of make the case that I do think those things are contributing, but I don't think they explain it in its entirety. And I do think some of this is real and something that we ought to be really paying attention to and trying to figure out what to do about.
One of the facts on that slide, if we can go back to the slide, is Iowa is the only state in the country where there was a statistically significant increase in the incidence. So I would assume that the funding of our cancer registry didn't change much between the two time periods. So if it's not that we're counting better, then maybe there's something really here that we're seeing more cancers, and obviously you're going to help us as we dissect the data to try to determine what that might be, or point to some things we may need to look at, whether it's nitrates in the water or ag chemicals, or what else, radon, other factors.
Yep, exactly. And I think I have some graphs that kind of make exactly your point. If there was ever a time it was because we were better at counting cancer cases, it would have been early on when those new cancer registries just were starting out in state health departments and just getting going. And over the years, they really kind of learned from the bigger registries, and they're getting better and better at it themselves, especially as things get a little bit more electronic. So you would expect there to be a narrowing, and instead there's kind of a widening.
And before we do a deeper dive, are there other facts on this slide that you want to bring to our attention right now?
I think we'll go through most of these, but really just I think the overall message that I hope people kind of take away from this is it's not one silver bullet that it seems like in Iowa that is causing us to be so high, but we're ranked fairly high in many cancers, many different cancer types. So you can see we're in the top 10 in colorectal cancer, where we're 7th. Melanoma, we're ranked 5th. Head and neck, that oral cavity and pharynx, we're ranked 1st in the entire country. Leukemia, we're 2nd. Kidney, we're 8th. Non-Hodgkin's lymphoma, we're 6th. Esophageal, we're 4th. And then there's a whole nother batch of cancers for which we're at least in the top 20, like prostate, breast, lung, thyroid, pancreatic, bladder, uterine, and brain cancer. So whereas Kentucky is really kind of propelled to the top by their really high rates of lung cancer, in Iowa it seems to be, again, this sort of mountain of pebbles where we're actually have pretty high rates across the board.
Yeah, that the melanoma really surprises me, because when you look at the world map of melanoma, you associate it with countries that have lots more sunshine, Australia, and I'm surprised to see a northern state like Iowa be so high in the incidence of melanoma.
Well, you'll be really perplexed when I show you the map of Iowa then, because the places where they're really high within Iowa is in the north, which is, again, odd. But yeah, I think that's everything on that slide I wanted to cover.
Okay.
I wanted to also point out some differences by race and ethnicity and gender that we see in some of these statistics. So by race, when we look just at the white population, we rank 4th in overall cancer incidence. So that's that rate of new cancer cases diagnosed among Iowans. But when we look at our Black population, we're actually 2nd in the whole country for non-Hispanic. That's what the non-NH stands for. We're actually 2nd in the country for the highest non-Hispanic Black among the non-Hispanic Black population. And then we drop all the way down to 35th within our Hispanic population, 14th for Asian Pacific Islanders, and back up to 9th for American Indian Alaska Native population. When we look by sex, we are 3rd in overall age-adjusted incidence for females and 6th for males. So it looks like we're a little bit higher when just looking at females and just looking at males, but we're pretty high in both. And and these trends are increasing for both males and females. And so when we look by sex and race, we can see non-Hispanic white males were 8th in overall incidence, whereas females were 6th. And non-Hispanic Black males were 2nd, and in females were 2nd. So very high in both those. And in Hispanic males, 35th, and females 37th.
So your data would seem to indicate that it's that very high incidence of our Black population that is kind of driving us and propelling Iowa to be so high in terms of the incidence of cancer.
It's definitely part of it. I mean, our Black population makes up a fairly small percent of our population, but it is a driver, I think, in terms of the Black population we have. They get cancer at higher rates. And, a couple of years ago, we put out our Cancer in Iowa report, which really focused on how we have one of the highest mortality rates in cancer among our Black population too. Whereas when we talk, and I'll talk about that a little bit later, but in our white population, we're very high in incidence of new cases, but quite a bit lower in mortality. So they're not dying as much as they are in other states. But when we look at the Black population, they're getting cancer at a very high incidence, and they're dying of cancer at a very high rate compared to other states. So that's a big difference that I think deserves a lot of concern and examination.
And I know we're going to get to the slide, but just to put things in perspective, in incidence, Iowa's number 2. Where do we rank in terms of mortality in the country?
I'm hoping that's on the next slide. I think
okay.
I want to say
Let me.
20,
I can advance.
There it is, that last bullet. We are 21st, and luckily that mortality rate is falling, whereas our incidence rate is rising. So we're kind of middle of the pack there.
So in mortality, one would think, okay, if you have a high incidence but a low mortality, that would suggest we're either finding cases at an early stage and we're doing a really good job of providing medical care and curing patients or controlling them. So what are the other factors that would contribute to a high incidence but a low mortality?
Well, I think a big driver of that is that we are not a high lung cancer state relative to other states, because it's fortunate, I think, that the mix of cancers that we are highest in do not tend to be the deadliest of cancers, is kind of the other end of that. And like you said, it's a great story in terms of among the screen detectable cancers. That's great that we're finding them and treating them, and they're not dying from them. But there's a lot of cancers I'm going to go through that are not screen detectable, that we're catching it. It just means that people are dealing with, as you know all too well, the effects of having cancer and having treatment for that cancer, which is a huge burden. Even if you survive, there's a lot of quality of life implications for those people. So it's still a pretty big burden. So it's kind of a good news, bad news story in that high incidence and lower mortality.
And anything else on this slide, Mary, that you want to bring to our attention right now?
No, I think I think I'm going to go through most of these here. And unfortunately, the labels didn't come out, but that's okay, because basically each of the points, kind of as it goes across from left to right, that's time. So it's a rolling 5-year average of Iowa's incidence rate. And we are yellow, so we are the one in yellow. And then the other lines represent states that are all surrounding us. So it's
okay.
Illinois, Kansas, Minnesota, Missouri, Nebraska, South Dakota, and Wisconsin.
Gotcha. So this slide, as you said, each line represents a different state, and this is the incidence. And what's the year here at the very left hand?
The left hand would be the 2010 to 2014 is the 5-year kind of period there, and then it increases. Then it goes to 2011 to 2015, and then all the way to the right is that 2015 to 2019.
Gotcha. So it's almost like 2010 to 2020, roughly. And this is Iowa. So even in the upper Midwest, even back in 2010, we had a higher incidence than the rest of the upper Midwest.
Yep.
And then ours has gone up probably a greater degree than the other states.
Right. Those other ones, even if you see a slight increase in some of those other states, they were not statistically significantly different from kind of being just considered stable. So that this shows we were really the only one going up at that slope of the
Mary,
line.
who are these two states here that just would look like they had the greatest decrease in the incidence of cancer?
I think those are, I think the dark brown there is South Dakota. And I think that dark blue, I think that's what that is Missouri, I think, down there.
Wow.
Mm-hmm. So yeah, it's just really interesting to see. Even if you think, well, maybe there's something going on in the Midwest, maybe we have these certain mix of risk factors. Well, I don't think that there's some variation certainly within the Midwest, but these are our neighbors, and we're still way out front of theirs, and that slope is kind of concerning. So yeah, you can go to the next slide. I think.
Okay. Yeah.
Through some of these individual cancer types.
So obviously breast cancer is that the second highest, or is that the number one for incidence in Iowa?
It's actually number one. If we put everybody together and don't look at things separate, male and female, even all together, it's number one. And it accounts for 14% of all the cancer cases diagnosed in Iowa. So it's a big one. We're 15th in that, so we're not way at the top, but we're also rising at the highest rate of all U.S. states at about 2.4% average annual percentage rate a year. So that's a little bit troubling. I will talk about some nuances to that on the next slide when we get there. But the good news is for mortality, we're ranked 40th, and that's falling more. So again, that suggests that we're catching breast cancer cases pretty early, and we're able to treat them. So that's a good news story. We are, kind of to your question earlier, are we high in incidence because we're aggressive at screening relative to other states? And we do pretty well in this one. Iowa, we're ranked 8th in mammogram rates according to the BRFSS.
Yeah.
Yep.
And just to state the obvious, when you do have a really good screening and you're screening all of the people who need to be screened, the reason you screen is you detect cancers at a very early stage when they're highly curable. So, having a good screening would lead to a higher incidence, and it would also lead to a lower mortality. And that's a little bit of what we're seeing. So maybe that's a good story about how good we are in Iowa for doing our screening.
Yep. There's always a but, though, which is the next one, which it's not a but it's, the incidence is increasing from 2015 to 2019, and the mammogram rate didn't increase during that time. It was high and it was good. We were in a good spot, but it didn't go up the same. You kind of think if that really explained it, you'd see an increase in that too.
Okay, Mary, I'll throw another one at you here. So we are going from 2D to 3D mammograms in those time periods. Is it possible, and we do more advanced imaging with ultrasound and MRI, is it possible that even though we're doing the same amount of screening, that our screening is getting better?
Yep, absolutely. And that would be a good kind of
hypothesis.
Angle on the story. Yep, I like it. So unfortunately, I don't know a good data set to really test that out on, but I'm sure there is one, and I think that's I'm going to make a note to see if we can look at something like that for sure. I do want to move to the next slide, though, and just kind of show what I've been talking about. So the top blue line there is the incidence, or the new cases, the rate per 100,000. And the green line at the bottom is the mortality rate per 100,000. And then that dashed line goes along with the right-sided axis there, which shows percent screened, according to BRFSS.
I see. Okay.
So you can kind of see that that's actually sort of dipped down a little bit. Hopefully, is back on the increase. One thing though to point out, which kind of could be kind of creating some of this high average annual percentage rate increase, is that you see that little dip there in about 2012 to 2013. There was a little drop in breast cancer that hadn't really happened for quite some time, and we never were able to figure out why that was, if that was real, if there was just a low year. the screening rate didn't appear to change that year. We were never able to kind of figure out what caused that. If there was something sort of artificial that caused that, or we missed some cases or something, then that would cause that slope to be going back up at a higher rate than expected. So there might be something kind of funny with the data there, but again, you can see even without that, when you look at the 2016 forward, you see that the incidence rate being, going up while that mammogram rate was not.
Mm-hmm.
So.
And this 80% screened, so that would be that 80% of the people who should be screened were screened. Mm-hmm. Is that correct?
That's correct. Yeah, of the eligible age.
Yeah.
Yes.
And that's was that fourth in the nation in terms of our screening?
I think eighth.
Okay.
Mm-hmm.
Okay.
So pretty good.
Let's go on to the next cancer that is prevalent in the upper Midwest in Iowa, colorectal cancer.
Yep, this is our fourth most common cancer in Iowa when we combine everybody together. We get about 1,600 cases per year, and those account for 8% of all cancer cases in Iowa. So we're seventh, and we have been consistently high in colorectal cancer. We're seventh, but fortunately we're overall, when we combine males and females together, that rate is sort of falling. But when we look specifically at males versus females, we see that the rate among males is decreasing at an average rate similar to other states, but the rate among females is not. It's declining ever so slightly, but it's not statistically significantly different from just a flat line. So we're kind of one of the few that's not falling in both males and females like most other states.
Mary, one thing, you don't address it in this particular slide, but nationwide, we are seeing a higher incidence of colorectal cancer in younger patients. And in fact, the fact that we're seeing it in younger patients has led to guidelines saying that we should start screening for colorectal cancer at age 45 instead of age 50. Did Iowa see that as well?
Yeah, so I don't know our screening rates in that particular age range.
But I mean the incidence of cancer.
Oh yes, Iowa is actually kind of one of the higher ones where we saw that climbing. Now it's still in that age group is still much lower. The rates are much lower than the 50 and older, but we did see it increasing at a pretty high rate compared to other states, for sure. We did do a sort of abstract review on a lot of our under 50 colorectal cancer cases, just to see, like, were these people are they starting to get diagnosed by screening, trying to kind of figure out how did they get their cancer diagnosed, and almost none of them did. Almost none of the recent cancer cases under 50 were detected because they just got screening because of the guideline change. Almost all of them had symptoms, and some of them for quite some time before it was recognized that they had cancer. So most of them had some sort of bleeding or something that compelled them to go to the doctor. So I think we still have a lot of work to do to get that age group in and sort of recognizing that they're now in the screening population so that we can catch that as soon as possible.
Yes, and obviously the data in and of itself doesn't tell us why younger people are getting colorectal cancer at a higher incidence now than they were 20, 30 years ago.
Yeah, I think that's been the focus of a lot of studies of people kind of trying to figure that out. And I don't think it's as clean as, people are more obese now, or I don't think they've been able to really pinpoint one thing that sets them apart and would explain that. So I think that's still a big area of study.
So we've made a big push nationwide in the last 10 years to try to increase colorectal cancer screening. We had the big push for 80 by 18 to try to get the whole nation to have 80% of eligible people screened by the year 2018. We were not successful in accomplishing that goal. It looks like we're still at, if I saw at 72%, or let's look at the slide again.
Yeah, I think it depends on which measure you look at, but yeah.
72% of our eligible patients have been screened. Is that?
Yeah, ever had any colorectal cancer screening? I think ever had maybe I'm afraid those are switched because I think it would be the other one would have to be higher. But I think we're in the upper 70s now for the one that was counting towards the 80 by 18 goal. I think we've
Okay.
made it to
Yeah.
close to 78%. I think we're at now, and that is increase. Those screening rates are increasing. But in terms of the data set we could look that ranked us compared to the other states, I think
Hmm.
lagged maybe a year behind, and so that's
And for those who don't realize it, this is a more difficult number to calculate than breast cancer screening. Breast cancer screening is mammography, and it's fairly easy to keep track of. Colorectal cancer screening can be colonoscopy, or it can be a stool test. And oftentimes, health systems colonoscopies might be done in one electronic medical record rather than the primary care. And I know, speaking for our health system, it's a much harder calculation to know what is our screening for colorectal cancer than it is for breast cancer. And the other reason that I don't think colorectal cancer screening will ever be as high as breast cancer, getting a colonoscopy is a much more cumbersome, difficult procedure that people don't want to get done, as opposed to mammography. Fairly simple, straightforward, and not a huge amount of discomfort associated with it.
Yeah, much less invasive. But we always joke we can send a man to the moon, but we can't make that prep taste any better. Can't figure it out. But that's usually people's least favorite, I think, is just doing the prep.
I thought you were going to say you can send a man to the moon, but you can't get him to do his colonoscopy.
Well, that too.
Let's go back to
Yeah,
our slides. Okay.
yeah, I think the other, just to add to your point, I think the other really tricky part of that calculation is just, colonoscopies every 10 years, but one of the at-home ones is every 1 year, but a different DNA stool test maybe every 3 years. And so that it's that up-to-date metric, what percent is up to date is the one that's really hard to calculate. And that was one
Yeah.
that wasn't
Yep.
available to compare us to other states. But I do believe that one we're, I think, ever inching towards that 80% goal.
Yeah, so this would show the dashed line is the number that have been screened compared to eligible. So even though we didn't get to 80% by 2018, this line would show a gradual increase in the number of people eligible for screening who actually have been screened. And this line is the incidence of colorectal cancer actually decreasing in Iowa. Is that correct?
That's correct. Yeah, for those over age 50, so that screen eligible population, which now goes down to 45, but at the time this data was compiled, we could only look at over 50, under 50. But for those who are in that screening population, the incidence is declining. But you can see in that blue line at the very bottom, that is the incidence among people age less than 50. To your earlier question, and you can see, it's much lower, but you can see it actually kind of inching up. In a different direction.
Okay.
And then that dark green line is the mortality, and you can see that's kind of inching downward.
Okay.
So that's a good story.
Let's talk now about melanoma, the most deadly of the skin cancers.
Correct. So that's 1,250 cases a year, just about, and it makes up about 6% of all of our cancer cases. Females were ranked 4th and males were ranked 14th in melanoma incidence. Everybody is rising about 3.5% average annual percent in their rates. And we're in the top 10 in terms of the rate of our rise of melanoma. So melanoma is kind of going up in every state. A lot of that could be because of better awareness and detection and looking for that. We've also kind of wondered, well, maybe things that people might have used to call dysplasia or something, they're now going ahead and calling melanoma and making sure to be really aggressive in treating it. So it's kind of hard to decipher how much of that is real, how much of that is detection. But essentially, melanoma is rising in almost every state. But I just wanted to point out that in Iowa, it's rising among the fastest.
Yeah. So, the main cause of melanoma is ultraviolet radiation. So that can either be natural sunshine or it could be a tanning bed. Has anybody mapped the number of tanning beds in Iowa compared to the incidence of melanoma? Do they go up in parallel over the last 20 years?
Yeah, that's a great question, and I haven't seen that, but now I'm going to go looking for it because that would be an interesting question. I think overall we see males in Iowa have a higher rate of melanoma than females across age groups. But what's interesting is among females, it's that under 45 population that has a little bit a higher rate, and I think that's because of that tanning bed use. So that's the only time where females have a higher melanoma rate than males is in the younger age groups where it could be explained by some tanning bed use for sure. And I just want to show the next slide, which is very interesting to me. And especially based on what we were talking about earlier, I don't know how much difference there is in UV exposure in terms of the strength of those UV rays from the north to the south of Iowa. But I thought it was so interesting that those counties in red have the highest melanoma rates. And I thought, well, maybe that's because you can see along the bottom those kind of hashed lines, which mean there wasn't enough cases down there. So I thought, well, maybe it's just because they're suppressed. We can't really tell what color those were supposed to be. So if you go to the next slide, this one was made by some of the biostatisticians that I work with. And it's looking at risk. Red means higher than average risk in the state. Blue means lower than average risk in the state, and white means average risk. And they used a special Bayesian technique so that they can get stable estimates even for small areas that don't have a lot of cases. So you see, even in a map like this, you see that pattern in the north of having high risk up there, whereas it's much lower in the south.
I wonder, I'm going to go back to this slide, and you talked about not enough rates. We know that this is a underserved area of Iowa, the southern tier, and whether folks just aren't getting screened and aren't going in to see the docs. I would bet that the number of visits to a dermatologist is greater in the upper part of the state than in this lower tier, just because of the availability of dermatologists is probably higher per population in the north than it is in the south.
Yeah, I think that's a great point. And that's something that we've really been thinking about at the Iowa Cancer Registry is when we show rates across the state, and we're really trying to figure out what drivers are and things like that. I do think that those lower couple tiers of counties in Iowa really deserve to be called out on their own sometimes, because just as you said, they're very underserved. I think that's a different socioeconomic profile a lot of times down there. I don't think they have access to the same resources that we have, closer you get to I-80. So we've kind of really thought about building out some regions in Iowa and really displaying rates by certain regions. A lot of times we see high rates along the rivers to the river towns. So we're really kind of trying to think through that of how to break Iowa maybe into some different regions where we could do some interesting reporting of some of these cancers and think through things just like you brought up. Is this an access issue and a detection issue more so? But possible that, I think different cultures and populations settled in different parts of Iowa, and there could be something to the, maybe the people in the north have fairer skin than the people in the south. I mean, there could be something to just the characteristics of the people that live there. But I just think it's so interesting to kind of think through those things.
Yeah, no, that's a good point. Yes, you think of the Scandinavians up in northern Iowa, and that the amount of pigment in the skin is a risk factor.
Yeah, those real severe sunburns are what can really elevate your risk, and the lighter your skin, the more you burn. So I can attest to that. So now I think we can move on to this leukemia slide. This is one where Iowa is consistently high also, and this has been for a long time. We have about 700 cases of leukemia per year, make up for that account for 3.4% of all of our cancer cases. And Iowa is second and slightly rising overall, specifically for females. And there's only 5 other states where that leukemia rate is rising, and Iowa is one of them. Our mortality, fortunately, is not second, but it's still 13th, which is pretty high. And it's higher for male. We're ranked higher for males than females, but fortunately that's falling a little bit. So it's going in a good direction. But this map shows, or this graph shows, age-adjusted incidence rates in Iowa broken out by kind of urban rural. So that orange line at the bottom, so the lowest rate of leukemia is in the urban, like in Des Moines or Iowa City or Waterloo. It's in those more densely populated areas. Then the next lowest is in the larger rural. So that would be kind of places like Mason City or Fort Dodge or Burlington, where there's some population centers, but they're still could be considered rural. And then that line, it's not a great color there, but at the top, the highest line, that's the small rural. So the most rural areas in Iowa are seeing the highest rates of leukemia incidence. Just one thing you asked earlier about some environmental exposures, pesticides and things like that. And unfortunately, I don't have nearly the background that my predecessor Chuck Lynch had in really some of those environmental exposures. But that's one that kind of makes you wonder about some environmental exposures.
Yeah. And then head and neck cancer. Just a little primer on that. So, 30, 40 years ago, almost all the head and neck cancers were the risk factor that was the driver for head and neck cancer was tobacco use and alcohol consumption. And now head and neck cancer in the oral pharynx, the tonsil area, the back of the throat, that is caused by HPV virus, and that has become the dominant driver in a lot of head and neck cancer. And maybe that we'll look at what the numbers are here and keep that in mind, that it really is a cancer that certainly in my professional career where the drivers for the head and neck cancer have switched.
Definitely. And we see that it's 650 cases, so 3% of all cancer cases overall, but Iowa is ranked first, number 1, and rising the fastest among all states in both males and females, I believe. So it's raising about 2.6 of that average annual percent change over 2015 to 2019.
Wow.
Fortunately, the mortality, we're 21st and stable overall, but if you look, if you divide that up by males versus females, we see that males are 17th and rising in that rank, unfortunately, whereas females are 32nd and stable. And if you can go to the next slide, hopefully the label showed up on this one.
Okay, before we go to the next slide, Mary, any information about, and I don't know how you would have this information, but HPV rates, not the rates of vaccination, but the rates of HPV infections. That's not, is that something that is a data that's available, or HPV is just so common and prevalent that we don't really have a data for how many people in Iowa have ever had HPV?
Yeah, I don't think there's a good way to track HPV incidence or prevalent, just other than I think that they estimate over 70% of people at any given time are infected with HPV. So it's very high. But one thing we did look at is the proportion, because, we know once people get, those labels didn't come through again. But we look at the proportion of the head and neck or the oral pharyngeal cases that were HPV positive, where we knew they had the test and we knew the test was positive, and that is absolutely, that proportion is increasing, just as you said. I think there's still quite a few people where it's negative and they still get that oral pharyngeal cancer due to smoking and alcohol and other exposures, but that proportion of what's HPV associated is going up at a quite rapid rate. And that next chart graph was supposed to show, those are the same Midwestern states that I showed earlier, and Iowa is in yellow. And so you can just see, it's a totally different ball game here. That's not so So that's not one, as you know, that has a screening test. So I don't know. I mean, I think your dentist or your primary care provider maybe can see a lesion in your mouth and hopefully get that worked up, or a kind of a mass on your neck, or you would know better, Dr. Deming, than how that presentation generally happens. So I think there's absolutely a component to people detecting it soon and working it up and figuring out what to do about it. But I don't think it's something that, there is no screening test. So I don't know that we would be more aggressive than other places at finding.
Yeah, I'm just thinking out loud. The University of Iowa has one of the leading is one of the leading institutions in terms of head and neck cancer surgeons. And so, wonderful training program, wonderful program. I think there's more awareness. Maybe some of it is is this tracked by the zip code of where the person lives, or
Correct.
where the diagnosis is made? So if
Well,
somebody
wherever they live.
in northern Missouri gets diagnosed at the University of Iowa, it would be tracked as a Missouri case?
It's a Missouri case. Yep, we collect that information for them and we ship it on down to Missouri, and that would go into their database.
Okay. But I would say that because of the really strong program at the University of Iowa, that maybe also dentists and oral surgeons and other folks are just more well trained. I'm not sure. For the oral pharynx HPV, it usually presents with the lymph node in the neck rather than actually seeing it in the tonsil. But
But you'd think even if it was a early detection thing, these aren't things that tend to just go away. So you think they're eventually coming out at some point, and aren't, it's maybe not as much like thyroid or some of the other ones where they might just never cause a problem. I would assume most of these tend to cause a problem eventually.
yes, yes, become symptomatic as they get to a higher stage.
Yeah. So I think this one, it's while a high proportion still may be due to tobacco and alcohol and things like that, I think the thing to really keep in mind, we were talking about with HPV, is that there's a vaccine, and maybe the vaccine can't help you and I and our age, or we've already had our exposures and things like that before, and didn't get the vaccine. But there's a whole segment of these cancers that could be completely eliminated by never getting HPV, which means, by getting vaccinated. So if we had a much higher vaccination rate in Iowa, and I think I have a slide on that hopefully later, our kids wouldn't ever our youth in Iowa would never have to worry about having an HPV associated head and neck cancer, along with an HPV associated cervical cancer, along with, penile cancer or vulvar cancer or any of those other HPV related ones. We can't really see the true impact of HPV vaccinations yet, because those are such kind of slow growing cancers. And I think it'll take maybe a few more years before we start to see the impact of vaccines. But it's just one that we actually know there's actually a vaccine that can prevent a cancer. It's one of the few things that we know how to prevent 100%, and people got the vaccine. So just wanted to push that.
Yeah, a great shout out. Yes, that we actually have a vaccine that will prevent the 5 different cancers that are caused by HPV. Yeah. So a little bit of a time check. We've got, because I do want to leave some time for questions and answers. We've got a live studio audience here, and we've got people that are logged in. So this is just a slide for all the other cancers.
Yep, this is just kind of remaining. I think I'm down to the bottom of the last couple slides here. We can go through quick, which is kidney cancer, where we're ranked 8th and rising. Pancreatic cancer is unfortunately one of those ones like lung, where and we don't even have lung, we have a screening test now. Pancreatic, no screening test. We've made very little gains in treatment in pancreatic cancer, very deadly. And we just see that sort of increasing every year. It keeps going up and up a little bit. And it is our number 3 cancer-related death in Iowa is from pancreatic cancer. And we're 17th and rising in that. And esophageal, it's not a very common cancer, 1% of all cancer cases, and only 250 cases a year. But Iowa here is ranked 1st and 11th in mortality. So that's a pretty deadly one, and one we're keeping an eye on too.
Wow. 1st in the nation in terms of the incidence of esophageal cancers per capita.
Yep.
I had no idea.
Yeah. And then I think this might be, hopefully, is there one last? Oh, this was just showing by sex. Again, the same Midwestern states that don't have their labels for some reason, but you can see on the left was males and on the right was females. So males is really where we're having really high rates compared to the other states in our region. And then you had asked about, how we rank in some of the lifestyle risk factors. Some of this data is pretty old by the time we can kind of get it ranked with the states, but Iowa's 21st in obesity prevalence and increasing. We're in the highest quartile for binge drinking. We have 22%. We're ranked 25th in terms of current smokers. I think we have around a 16% smoking rate. Categorized in the second lowest quartile for percent engaging in 150 minutes of physical activity per week at about 48%. So not doing great in terms of all these risk factors, but we're not at the bottom, which would explain why we're at the top for incidence. We're kind of middle of the pack here. So again, really nothing that really stuck out as this is it. If we focus on this one thing, then Iowa won't be number 2 anymore.
And Mary, back to your job as director of the Iowa Cancer Registry and being an epidemiologist, and what's the process by which you and other scientists look at the data, then use it to do a deeper dive into trying to understand the data and correlate cause and effect, and what is the process of using this data to then learn more about what's actually going on?
Yeah, well, and that's unfortunately at the registry, we're real good at surveillance and tracking, but we're not always the best at kind of that deep dive. So we really rely on our research partners and cancer control partners around the state and around the country to kind of help us figure out what's going on. So, as we're both on the Iowa Cancer Consortium board, there'll be a topic at our next conversation is how to really get this information out to people who can use it to help figure out what's going on. I mentioned really dividing the state into regions so we can kind of dig into seeing if there's certain parts of the state where we can invest some resources to see if we can make a difference. Really looking by those different population groups, by race. Is there something, we have some research projects going on in the Waterloo area to see if we can engage our Black community in Waterloo to really try and figure out what can we do, how can we support that population in getting, more prevention, more screening, and really reducing that incidence and mortality rate. So really what we try to do is get that information out into the hands of people who can take that deeper dive and figure out what's happening, and then keep tracking it to see what's working, what we can do more of, those types of things. But
And I know one thing that you showed us a bit, especially when you got to the melanoma and some of those graphs and charts that overlay the state of Iowa, that you have really good data and you make it available to folks. So if you have anybody in the state that's doing research and wanting to do a deeper dive, correct me if I'm wrong, but this data is publicly available and you help folks do the deep dives into the data, correct?
Absolutely. Yep. We have a lot of tools on our website at the Iowa Cancer Registry. If you go there, a lot of mapping tools and some, kind of easily point and click query tools. We'll also work with you if you're a researcher and want to use the data for a deeper dive. And we have processes by which we can release that data. We work closely with a lot of the local public health departments and the state health department to really work with them on their programs and kind of figuring out what we can do. So at every level, we try to push that data out there so that people can use it and figure out how to reduce the burden of cancer in Iowa.
Well, great. So let's do some Q&A here. So we've got some questions here from our live studio audience.
Mary, do you find that, or do you keep that as to people's their profession, like farmers, for example, since we're such a large farm state, do we find more cancer in our farmers?
Unfortunately, we don't track occupation at the registry, but we do participate in large cohort studies like the agricultural health study, which was actually started by, again, my predecessor, who is the former director of the cancer registry, Chuck Lynch. And that enrolled over 50,000 pesticide applicators in Iowa, and another several thousand in North Carolina, and really studied those exposure, water, were they on well water, arsenic levels, pesticides, all kinds of things. And so there is quite a bit of literature that comes out of Iowa that connects some of those exposures to diseases like leukemia or lymphoma or some of those things. So we definitely do have that information and participate in those studies, but we don't have it at the registry where I can say this profession gets cancer more than this profession. We're not able to collect it for everybody. It's not always readily available in the chart.
So maybe, and the other question was, what is the personal data that comes with each of these cases? So obviously, age, gender, racial
Race,
designation,
ethnicity, marital status.
marital status, zip code in terms of where they live.
Yep. So all that kind of geographic area data. We also know their insurance status, whether they had some insurance coverage.
We don't know their income, right? But we do know. So a little bit of a surrogate is like their insurance status. Do they have private insurance? Do they have Medicare? Do they have Medicaid? Or are they uninsured? That's that data that tracks with each cancer case. Correct.
Correct.
Yeah. Okay. Other questions?
Dr. Charlton, I was looking at your stats there for Iowa, and I don't like them at all because they're just so high, and I'm just shocked. But the good thing I learned tonight is that we're going in the right direction, and the right direction starts with the screening, and because of that, our rates are starting to go down. I've done some research here, and it looks like Iowa is ranked 10th in relation to radon and radon gases and things like that. So that might be one of the reasons why we're so high. One of my overall questions is that you do track a lot of statistics here in Iowa and United States. Do you have the same types of statistics, let's say, comparing U.S. to South America or U.S. to China and that type of statistics?
Yeah, we do participate in what's called the Concord study, which they are an entity, I think, out of the UK that compiles cancer registry data from all the countries that have them and can meet some kind of standards for how they collect the data. So unfortunately, I'm not as active in looking at that, and that's a great point, and I should be to be able to show that. And I don't have off the top of my head really how the U.S. Ranks compared to other countries. I know in mortality we do really well. If you're going to get cancer, this is a good place to be treated for it, and we will treat you as much as we possibly can. So I think in mortality we do well, but I'm not exactly sure how we fare in terms of incidence compared to other countries.
A good resource, Tim, the American Cancer Society is one of the organizations that puts out the World Cancer Atlas. And I think that's a resource that's available to be downloaded and looked at if you go to cancer.org, which is the American Cancer Society website. You can find your way to the World Cancer Atlas, and it shows some of the same statistics that Dr. Charlton showed for Iowa in a global data pool.
Yeah, that was such a good question. I kind of get my blinders on with Iowa, and then just looking compared to the other states. But that's a great resource.
George, do we have any questions from our online audience?
Throughout the entire evening is how much of the reporting is affected by Iowa's elderly population. We're always reported as one of the oldest states, so therefore, do we have one of the highest incidents of cancer and cancers, and is that got a lot to do with this?
Yeah, that's why I talked a little bit about the beginning of it. It's very hard to explain, and I don't think I articulated it very well, but all of the statistics I presented today were age adjusted. So it basically forces our population to be the same age distribution as every other population. So we kind of we take our rates, our age specific rates, and we apply them to a standard population. So age cannot really explain any of what I went through today. But it does explain why Iowa does have a very large burden of cancer, and that is because we do have a large older population. But when we compare states, we always use that age-adjusted age standardized rates. So so not for what I talked to, well, not what I talked about today, unfortunately.
Yeah. So if you just use raw incidence without being age adjusted, we would probably rank even higher in some of those in terms of the incidence per population.
Correct.
Well, Mary, this has been wonderful. Thank you for taking the time to be with us tonight, and thank you for all you do to help us by being the director to help keep track of this data. That's just incredible, and really to help reduce the burden of cancer, we got to start with the data and to let the data help drive us to see what's the associations and how can we then learn more about cause and figure out a way to collectively reduce the burden of cancer.
Yep, definitely. And I appreciate you talking through it with me. And that's what we love to hear from people, that gives us ideas of where we can point our resources and analytics and figure out what's going on.
Well, Mary, I think I'm seeing you tomorrow virtually as well, aren't I? Yes.
Yep.
So,
yep. We talk about the same thing again.
Dr. Charlton and I both serve on the Iowa Cancer Consortium. She is the president of the Iowa Cancer Consortium, and I think we have a board meeting tomorrow. So we'll talk some more about it tomorrow. And I want to thank everybody for attending. Please join us again next week. If you know someone that would be interested in the information tonight, this program will be available on demand at the Mercy One Cancer Center website and also at the Above and Beyond Cancer YouTube channel. So please come and join us again next week. Thanks, everybody, and happy holidays. Program's over, show's over, but we'll make this the link. Are we still on it?